Good afternoon, everybody, and welcome to this, the first live question time with a focus on wound care. First of all, can I take the opportunity to thank Wound Care Today, ABHI, and SDMA for making this event not just a possibility, but a reality. When we first got together to look at this was going to be a straightforward summit, but we decided to actually push the boat out and do something a bit more challenging and take some of the challenges that you're facing on a day-to-day basis head on. So hence, we're doing a question time today. My name is Christine O'Connor. I'm privileged to work at Accelerate in East London and to work with Alison Hopkins. And I'm your chair or your host, whichever way you wish to approach it, for the next 90 minutes. When I look around the room today, I think we have to consider also those who are tuned in on Facebook Live with us today. I think we're all here because there's a kind of golden thread that links us all together, and that is about our passion for wound care and our passion for making a difference to people's lives. And I believe that's why we're all here today in terms of looking at how we can make things forward. This common thread is really critical for us all to hold on to as we go through this session today. But to set the scene, I'm not going to spend a long time talking to you about the financial state of the NHS. I don't need to do that. We all know what it's like. And you know what? If we can change it, well, good luck to us all on that one, because it's been in that state for many, many, many years. And I'm not either going to feed the despondency in regard to the situation we find ourselves in with the nursing workforce. It is what it is right now. We cannot change it. We have to work with it, and we have to find solutions about how we do things differently to help us focus on what needs to be delivered and to make life motivational and pleasant for those who work on our front line, caring for our families and our friends. I am, however, going to throw at you some facts because I think this is quite important for you to consider as we go into questions with our panel. In the main, and I think we really need to remember this as we start to look at some of the things that we want to explore today, wound care services and the role of the TVN are hidden in the tomes of contracts, and are therefore not only difficult to measure and isolate in terms of cost and impact, but become part of a huge, great contract that may sit with an acute trust, a community trust, or whatever organisation that wound care is being delivered via. And I think that's a really important point. Primary care remains very agnostic about the delivery of wound care, and simply becomes a vehicle for delivering the prescriptions for the nurses as they constantly request things that they need to care for their patients at the front line in terms of the community nursing. Wound care makes up 70 to 80% of the daily caseload of a district nurse. And the majority of that wound care is concerned with the lower limb. And roughly 50% of those patients have bilateral conditions. The fact is that actually, where there is a history in investment in specialist intervention over a period of time, the caseload of wounds accounts for less than 30%. I want you to hold on to those numbers. That we're talking about district nursing as 70 to 80% of their caseload on a day-to-day basis, and yet where we know there is a history of specialist intervention, this caseload of wounds can be reduced to as much as 30%, and I think that's significant. I'll probably get shot for saying this, but I'm going to say it anyway for those who know me. Commissioners do not understand how to commission wound care. Not only do they not understand how to commission it, they don't understand it. And I think that is very significant because the fact is that in this audience, I'd be interested, have we got any commissioners in the audience? Ex-commissioner. Have we got any commissioners? How often do we have commissioners in an audience? We have providers, we have suppliers, but it's rare that we see a commissioner in an audience of this nature. And I think it's hugely significant that, because these are the people who place the contracts. And we spend hours on end going round in circles, working with each other, trying to find a solution when it may be sitting in another room somewhere else in a very great building. So commissioners and primary care have a key role to play in effecting any change which may be coming through from the wound care strategy. A question. Do we really understand? I mean, these are words that we use all the time. Do we really understand when we talk about value-based care? Or is it just a phrase that we throw about because it sounds good? I'd just like to have 5 minutes to talk to you about value-based care. Well, okay, what's your view of it? How do you look at it? What's your glasses look like? And I think we haven't got any commonality of theme around that. And last but by no means least, let's not forget that the industry has been the strongest and most single-minded delivery vehicle for education in this specific space. And we should not, in our efforts to manage resources, rob Peter to pay Paul. And I think that's quite an important thing to grasp as we go forward. So for me, today, we're here to bring clarity and transparency to some of the questions that I hear on a day-to-day basis, and it feels like we go round in circles trying to find an answer to. And you all have different viewpoints about how you've met with the individuals that are sitting here on the panel today, and what answers you've received from them, and whether they all stacks up in your world. So today is about getting that clarity and about getting that transparency. But first of all, I want to give some rules of engagement. And I think that's quite important given the fact that we are actually live today. So first of all, let me say, this is not about how we annihilate people in this process. So if you're sitting there on a question that you've been steaming about for months, this is not your opportunity, okay? It is not your opportunity, okay? The other thing I need to say is I am absolutely so pleased that all of these individuals have agreed to sit here in front of you today and to be streamed live. That is no mean feat to ask them to do that. And I think we ought to be grateful that actually they've given their time up to do this today, and we need to respect that. And I think last but by no means least for me, we need to respect each other in this. We have to hold a respect for each other in the way we're asking questions and in the expectations. I'm not actually expecting people to kind of just dig, because if you do, I'll stop you. And if I feel something's going too far, I actually will stop the question. So I think you need to be aware of the fact that I won't have any worry about that, because at the end of the day, unfortunately for you, I'm the boss today. Okay. All right, so moving on to our panel. Okay, so let me introduce our panel. We have sitting to my right, first of all, we have Joe Gander, who is the Director of Clinical and Product Assurance for Supply Chain Coordination Limited. Sitting next to Joe, we have Julian Guest, who is a prolific health economist and author of Burden of Wound Care Study. Sitting next to Julian, we have Una Adderley, Professor Una Adderley, who is the Director of the National Wound Care Strategy Programme. Got it right, Una?
Nearly.
Remember
I'm not Professor.
All right, okay.
Thank you for the
Doctor,
promotion.
I'll give you Doctor then, shall I, Una?
Yeah,
Is that okay?
One. That's great.
It's Professor next to you with Julian there, I
Indeed,
think.
you got us round.
Okay, sitting next to Una, we have Alison Schofield, who herself is a TVN and a founder of TVN Together. And next to Alison, we have Miranda Gordon. This is a long title, Miranda. Head of Category Wound Care and Infection Control, Tower 3. Okay? Is that fair? And finally, representing ABHI and SDMA, we have Richard Cornwell. And I haven't put the bomb under your seat, Richard, I'm afraid. Okay, so before we get started, I think it would be helpful if our panel just take a minute to say a little bit about themselves, and then I will go straight in to a question, and I will start receiving questions streamed, and then I will take questions from the audience also. Okay? So we're clear on the rules, we're clear on the way forward, we've got 90 minutes of excitement, it needs to be dynamic, okay? So let's go for it now. Jo, would you like to say a little bit about yourself?
Okay, my name's Jo Gander. Clearly I'm the Director of Clinical and Product Assurance at NHS Supply Chain. I'm a nurse by trade and spent the first 25 years of my career in industry working in medical devices and pharmaceuticals, including wound care and continence, among a lot of other areas. I came back into the NHS in 2008 as a commissioning group director in a Pathfinder site in North East Lincolnshire. We had responsibility for health and care budgets, and at that time I was responsible for the prescribing budget as well. From there, I moved into the national team, which was the digital technology team, now known as NHSX, where I was part of the team that looked after GPIT, Premises GP Access Fund, Digital Child Health, Health and Justice, amongst other things. And then I came out to the nursing directorate on a stretch assignment, working on winter pressures before moving over to supply chain about 18 months ago.
Excellent, thank you. Julian?
I'm Julian Guest, I'm a health economist. I set up a health economics consultancy called Catalyst Health Economics Consultants 30 years ago, and during that, in the last 30 years, I've conducted a broad range of health economic studies in a wide range of areas of medicine, therapeutic areas, right across the globe. And I suppose I ought to say, just to reinforce, I'm the author of the Burden of Wounds study, which I'm sure you've all become aware of.
I think that's been quite a seminal piece of work for us all, I feel. Una?
Hello, I'm Una Adderley. I'm a nurse. I'm a district nurse, tissue viability nurse, Queen's nurse, and have spent most of my career in the community after I very quickly worked out the hospital wasn't the place for me because I kept getting into trouble for asking questions. And that probably sums up my working career. Latterly, I've been working in universities, teaching undergraduate nurses, postgrad, PhD students, teaching them to ask questions. My doctoral work was in judgment and decision making, and I've also been involved in research as well. It's a bit of jack of all trades. But I guess my particular interest has always been about bridging that gap between the clinical world of practice, the academic world of research, and the practical world of all the other stuff that goes with wound care. Is how do we bring that together and how can we make things better?
Thanks, Una. Alison?
Hello, my name's Alison Schofield. I've been a nurse working in the NHS for the past 20 years. I am a tissue viability nurse who is currently working for the NHS, so I am at the coalface, as it were. I co-founded TVN Together, which is a representative of tissue viability nurses around the UK in communication, support, and to each other, and some of the TVNs are, I can see in the audience today. So I'm very passionate about tissue viability services, about support for tissue viability nurses, and education support around wound care today.
Miranda?
Good afternoon, everybody. My name's Miranda Gordon. I'm Head of Category 4 Wound Care and Infection Control. I probably stand out as not having a clinical background, but I've worked in procurement for 15 years now. So I've been on the NHS supply chain contract for 10 years, 10 happy years, and prior to that I worked in the food industry. In terms of our team and the work that we do, we're responsible for the end-to-end procurement process, so everything from clinical engagement, developing of our strategies, all the way through to the procurement exercises and then managing the contracts throughout the life of them.
And Richard?
Last but not least.
Exactly.
Good afternoon, everyone. My name's Richard Cornwell. I am a managing director of one of the suppliers of wound dressings to the NHS. Which supplier doesn't really matter. I'm here to represent ABHI and SDMA today. I'm the chair of the Special Interest Group for Wound Care for ABHI, which is the reason I'm here. I've spent 25 years within medical devices, med tech, a good proportion of that in the supply of wound dressings into the NHS.
Excellent. Thank you very much. So this is a bit more about relaxing now and getting into some questions and recognizing this is not like a normal conference. It is about, you know, a bit of relaxation, a bit of togetherness. So I'm going to start with, I am going to try and adopt a question time approach to this. So I'm kind of put some things together so that actually there are parts that individuals can answer as we go along. And I'm going to open up by asking a question around tissue viability nurses. And there's been some statements which suggest that we should be fiercely protecting the role of the TVN. And other phrases that are suggesting that the TVN specialist role is perhaps dying. And how can the new strategy actually reignite the interest and role for the TVN? And you know, there are other people who are asking whether we're actually taking the role of the TVN nurse specialist seriously. Alison, would you like to kind of open up on some thoughts on that, please? Because I'm sure that's kind of gotten to the heart of where you're at.
Yeah. I just want to make a point, though, first of all, that as tissue viability nurses, we're not militant. We're not, you know, not wanting...
Really?
Well, we might be. We're not wanting to not work, in, you know, as an integration with other... Because we know it isn't... There are other services that deliver wound care, and we all need to work together. I think for tissue viability nurses, and I can speak for the voices of many because we've had lots of these conversations, is that we don't actually have any proper structure behind the service as a specialism. So, for example, you've got infection control, vascular services, podiatry, who are very, have their services which are very sewn together. Whereas I used to be a district nurse, and we kind of always were the dumping ground for everything as a district nurse. There's no closed door. And it feels a little bit like that now with tissue viability. There's such a focus in acute around pressure ulcers. It's become a validation service. You know, a lot. We see everything and anything, you know, and you think about nursing care homes, primary care, and all that delivery of that education there, that the tissue viability service feels very under-resourced at the moment, and it worries us that the people coming into it, there isn't any recognised qualifications towards it. And it just feels like the jobs are being debanded, and that we feel with this, like the National Wound Care Strategy, we're all very excited about the work that's coming from that we would like to, we want to know where tissue viability is going to sit within everything going forward.
Okay, so I'm going to pick up a couple of statements that you said there. You talked about a dumping ground, under-resourced, debanded. Does anybody want to pick up on any of those thoughts around tissue viability on the panel? Does Una?
Surprise, surprise, yeah. I think tissue viability nursing is absolutely key to how we move forward. And I would look at tissue viability nurses as one of the, if not the, likely clinical leadership roles within what we're trying to do. Having said that, I think that it would be, I think we need to look at it quite strategically. Tissue viability nurses are generally quite senior nurses and therefore paid accordingly. And I don't think every patient with a wound needs to be seen by a senior tissue viability nurse. But what they do need to do is have an assessment and a diagnosis and a treatment plan from someone who knows what they're doing. So I think we need services that are probably led by tissue viability nurses, possibly working in partnership with podiatrists or medical colleagues. And we have got to find a way that actually we get to that. But we cannot afford a system whereby everybody with a wound needs to be seen by a Band 7 TVN. It's a more complicated. I also think you make a really good point about education. One of the things in the strategy we will be pushing for is that anybody who is working in a specialist advanced level in wound care should be educated or on the way to being educated at master's level, because this is a senior role that needs the appropriate education. And we're not saying that to be putting barriers in the way of people. We actually think that increases the chances of people being able to get access to the education they need. Interesting you said about recordable. I only yesterday discovered that there is an NMC recordable qualification on tissue viability, which I didn't know till yesterday, but only in Northern Ireland. So I'm trying to unpick that one, because I don't know what that means, but it does sound to me as though this is another part of what we need to do to join up.
We have been told about that as
yes.
well.
So there's all these different threads we're trying to pick up and weave together. But I don't think tissue viability nurses are the only solution, but I think they are a very important part of the solution.
Do you think, Una, there's enough? I know there's one or two of us on work streams in the national strategy, and I know some of the TVNs feel that there should be more within the work streams.
Way more than one or two. I can't give you off the top of my head how many there are, but I've got 30 of them-ish involved in the expert reference group, which is part of the supply and distribution group. I've got tissue viability nurses in every single work stream, but we have to make sure that actually we are inclusive and we get away from this silo working. So we've got to make sure they're at the table, which they definitely are, but we can't exclude other professions as well. This has got to be a joined up approach.
Richard.
Not.
I would agree exactly with what you're saying there, Una. I think in order to generate a service that improves patient outcomes, clinical outcomes, absolutely improves the patient experience whilst driving down the cost of the NHS is absolutely what we're all aligned to. We as industry see the TVN as being the focal point for that. It's where care starts. I agree with you that you can't then have 1,000 TVNs per CCG because that doesn't make sense. But I translate that into an industry standing where we'd have a sales manager or a sales director at the top.
Yep.
He or she doesn't make all of the calls to the customers. He then directs and coordinates a standard approach that goes out and makes us more effective. The TVN is the focal point for effective care within a local health economy.
Any other comments? Do we want to comment from anybody in the audience?
But then can I just
Sorry,
say,
Alison?
Obviously, like I say, I am working in the NHS today, and in the area I work in, I am the sole TVN covering a very large geographical area, doing strategic management, delivering the education, clinically seeing the patients.
And you need a team to work with.
We need more resources to work with. Yes, I can be at the top of that tree and disseminating out and leading that, but in a lot of areas that resource seems to be diminishing.
I was about to say, I think what I'm seeing out there is TVNs moving away from their specialism and a reduction in the number of them out there. So in some of the areas I'm working now, I've got, a 0.1 whole time equivalent, or I'm somebody doing a 0.1 whole time equivalent and district nursing at the same time. And I think there's some challenges around that. Jo?
I was just going to add, from my previous life as a commissioner, the thing that really sounds that needs to be here to support this is actually a specification for the service. Yeah. We do that for every other service, and we do it for cancer services, for whatever the speciality is. We have a design of what we expect as outcomes from the service. Rather than it being focused on the number of people we have delivering the service, it's literally focused on what you're trying to have as outcomes. And I think that's where the work of the National Wound Care Strategy Programme is really key in being able to inform that. But for me, that's where we need to go.
And the work, from Julian's work as well, we obviously data is key to, and I know years ago there was some work that was talked about measuring, the number of wounds. We seem to monitor and gather a lot of information around pressure ulcers, and obviously the work that you did, Julian, was really key. And we can we see the phenomenon that's out there, and that we need to all work together. We need to come to educational events like we have today. This week we've got primary care nurses, we've got nursing, the general nurses from all backgrounds that need that education in wound care to be able to deliver, because you know, as TVNs, we are a limited resource. We can't be, as you say, Una, at every patient and every wound.
Julian, sorry, Una.
As I say, you don't just need the education, though. You need a service that has been commissioned in a way
Correct.
that allows people to do what they've been educated to do.
And certainly in my experience, that service is not directly commissioned. It's part
I'd
of
agree.
a whole big bag of whatever sits in a specific contract, and that's why it's so difficult to know what we're dealing with and what we're measuring. Julian, do you want to make any comments at all?
Yes, I'd like to make 2 points.
Please.
So our original burden of wounds study for 12-13 showed that on average, less than 5% of all patients with a wound actually saw a TVN. But I think the important point to recognise is that the majority of patients with a wound are seen in the community, increasingly so now by district nurses, and more importantly by healthcare assistants.
Yep.
So I think these are the people that need to know about wound care. And maybe it needs to come down from top down, from TVNs, but there needs to be a mechanism in place to improve education in the community.
I think I absolutely concur with what you're saying. I think that what I'm hearing is, and what I'd like to see personally, is more visibility of tissue viability nurses in the community. And I think we've got to kind of move in that direction. That's the way the NHS plan is going, and we kind of need to get those people there supporting the people who are actually going to be delivering the strategy, Una.
Yes, that I would agree. And it's not just healthcare assistants. Sometimes it's about people recognising what they're looking at, even to the point that this is beyond my skills. And I would say the same about GPs. That
Absolutely.
too many GPs, somebody comes in, they prescribe antibiotics because they don't recognise what they're looking at. So it's not just about healthcare, it's about everybody in the system recognising what they need to recognise, recognising whether they have the knowledge and skills
Yep.
to deal with it or whether it needs to be passed on.
Okay.
And I think we do need to look at how we organise that.
Okay, is there anybody wish to make a comment before I move on to the next question? Okay, so our next question is for you actually, Una. It's about how the strategy developments from the work streams are going to be implemented. This question comes from Kate, and she's asked about how it's going to be implemented across England, Scotland, Wales and Northern Ireland. So
Well,
I think you're going to have to spread yourself a bit thin there.
I can
and who'll
answer
do
that
it?
part. Firstly, the National Wound Care Strategy Programme is only for England. So fortunately, it's tough enough delivering on England, let alone Northern Ireland, Scotland and Wales. Having said that, we are in conversation with those countries, because why would we not be? Because we're all working together. So while it is up to them to decide, because they all have their own healthcare systems, they do some very good stuff in the other countries, and it makes sense to learn from each other, which is why I learned about the NMC thing yesterday, because I was talking to the Northern Irish nurses. So if we bring the question back to England, I can't answer that question easily, because this is a huge, huge question. What I do know is it's relatively simple to write a set of guidelines. It is much, much harder to get those guidelines implemented. Implementation is incredibly challenging. So I think one of the most useful things is, I think those of us all involved in the strategy, is we recognise that and we know it's not going to be achieved overnight. What I can say is, and I think this goes back to one of the earlier questions, is if we are going to get commissioners to prick up their ears and listen to what we're saying, we have got to provide them with a robust financial case that lays out the benefits and risks. So what we have done is we've commissioned an external consultancy to start developing that business case for implementation. Because unless you've actually got a toolkit that you can take to your commissioners and saying you really need to be investing in this because it makes sense both clinically and financially, they are not going to listen. And in fact, again, I was on the phone to somebody yesterday and she presented, I was dead impressed. She was a radiographer. She got her head around this topic and was converted. But she said, I cannot get it past my finance director. And she was a commissioner. So we have got to help people get that case to the people to actually get on. Because I think the key does lie with commissioning.
I agree.
Writing the guidelines was the pathway is quite easy. I could have done that with my eyes shut. But the next bit is really, really challenging. And we've got to do it. I think we need to drive it both from the groundswell, people like you in the room who presumably are here because you're passionate about it. We've got to do it top down from policy. We're in conversation with some very, very senior people in NHS England who have never paid any interest to wound care before, but are really interested in what we're doing. We've got things like the sequin. Now, I don't kid myself, the sequin is going to solve the problem, but it's been already enormously helpful in getting the topic onto the table for people to talk about.
I absolutely would agree.
So it's going to be a multitude of things.
I don't think we need to underplay the importance of the Commissioner in this whole way of going forward. And I think it's critically important, the points that you're making. Right at this minute in time, certainly in the work that I do on a day-to-day basis, commissioners do not recognise the potential opportunity that is presented here in terms of the work they're trying to undertake. And let's not kid ourselves, commissioning is in quite a turmoil at the moment as they're going through their own changes. And to a certain extent, when you've got a chaotic environment, that creates opportunity. So it's a question of how we maximise that generally to get the swell of noise level that you're talking about, yes. Una. Does anybody else want to comment on that while we're... Joe?
On the commissioning part, I think the other thing is that unless you've actually worked in commissioning, when you're actually looking at the priorities within a locality, that varies from place to place, depending on what the local needs are.
Absolutely.
And it is really difficult for a commissioner to look at the priorities they have in their area and decide which is the most important. So it's how you actually get that message, and it's not always about it being seen as something separate, but if it can be seen as how it actually contributes to some of the other priorities and some of the other comorbidities, I think that's probably another area.
Okay, can I pick up on that actually, because clearly the focus generally are on what people might term the big ticket items. So we automatically go to coronary heart disease, diabetes, the favourite obesity, and we know from, I don't know whether I'm correct in saying this, Julian, from your work, that actually the costs of wound care are greater than that of the cost of obesity, or equal to?
It's comparable.
Comparable.
Sorry, it was comparable in 2012-13.
Where are we now? Can you say?
I don't want to say right now, but we're now in 2017-18, and we know that things have changed.
Okay. Would you say things have changed for the better in regard to the wound care side, or the other? I know I'm putting you on the spot.
Depends what you mean by better.
So what I'm trying to say... here we go. So what I'm trying to say here is, if you were a betting man, would you say that actually, we've got a bigger challenge financially with not managing wound care or wounds effectively? That's a loaded question, I realise.
Well, it's no secret, because I've already presented last year at Wounds UK, that the number of wounds has increased since 2012-13. The resources that have been utilised have increased, and the costs have also increased.
Okay, so it should be perceived as a big ticket item for commissioners.
The major issue that's apparent to us, the major change in the last 5 years, is that there has been a shift in the way wound care is managed. So there is less specialist involvement, and more patients are managed in the community by district nurses and healthcare assistants. So when we talk about guidelines that we just mentioned, it isn't just the commissioners or the CCGs endorsing the guidelines. The clinicians, the coalface, need to be made aware that those guidelines even exist.
Okay. Any more? Richard?
Yeah,
okay, Alison.
For those that were in the audience this morning, we heard from a data perspective that the data doesn't exist because there's not been an importance applied to wound care over the years. The data doesn't exist. So a typical CCG doesn't necessarily know how many patients it has with a wound, where those wounds are being treated, what the cost of those wounds are. So from a commissioning point of view, how would they know exactly what they're commissioning?
Okay, so I'll take the challenge there, Richard, because actually, I said earlier, we know that at least a large percentage of the wounds that are being seen by district nurses out there are lower limb. We know that. And we know that it consists of at least 70 to 80% of a DN's workload. Now, it doesn't take the world's greatest mathematician to work out that actually that's quite significant of a DN's workload on a day-to-day basis, and that actually if you were able to work that differently, it would release high levels of productivity back into the system to actually deliver on other areas that are challenging too. Una?
I was going to say, I think you're right, because Julian's work and the work you talk about, we know the problem is very big. We know it's getting bigger. What we don't have, and this seems to be the hiccup, is that locality level precision data. And that's where they say, oh yes, well, it's a big problem, but I don't know what it's like in my area, therefore I can close down on it. So I think I agree with you. We've discussed this morning, data is so important
Absolutely.
in making the argument. Julian's work's enormously helpful with the modelling because it gives us a feel of what's
Starter
going.
for 10.
Yeah.
Can I just go to Alison first, Julian, and then I'll come to you. Alison.
So, we've got some documents, we've got some navigational tools in place that are coming out of the strategy, and we talked about that the generalist nurses who are delivering care on the ground, that needs to be fed down to them. Who's delivering it to the CCGs? We've got a lot of buy-in from NHS England, but who are the people in the individual CCGs that are going to take this and say, look, this is what we need to be following, that we need to be investing in wound care in our services? Who are the people who are going to do that? Is it us as clinicians? Is it?
Good question. I'm sure there's a chap who's actually streamed in called Mike who thinks you'll probably read his question in advance here, because that's the very question he's just asked. So I think that's a real big challenge as to how that's going to be handled to get that message across.
Do you want me to answer that? Because I know
I'd love you to answer, and then I'll go to Julian.
Right. What is interesting is I think it's going to be a combined effort, because these things always are. I'm a great fan of the multi-pincer movement, because if you keep putting polite pressure on lots and lots of points, you generally get movement forwards. What's interesting is when I first started this job 18 months ago, I couldn't get any commissioners to listen or talk to me. Nobody was interested. Now I'm regularly getting commissioners are contacting me. So I think we are starting to get that change. But it's not going to happen overnight. And I don't think it should be the responsibility of any one group. I think everybody has a duty to actually be aware and to try and improve the data and just keep gently pushing. Well, not gently, put some welly into it, but to try and keep the messaging going. We can do that at a national strategic level, and we are doing that. I think it's our job as well to give you the ammunition, wherever you're working, to start doing it there. It is tricky because we don't have that detailed data, but we are definitely moving forwards in the right direction. And hopefully in about 3 or 4 months' time, we will at least have some sort of support for you for implementation to make that financial case as well. Haven't got it yet, but we are working on it.
Okay. One more comment from Julian, then I'm coming to the audience.
My only comment was just to address Richard's point. I've been contacted by individual CCGs that have asked me to estimate or model different wound types in their catchment population, which I've been doing.
I think that's an important point. Okay, audience, over to you. Can I have a question, please? Don't all rush at me at once. Oh, good. One from the back there. Can you say your name and clear on your question, please?
My name's James Saunders. I'm from 365 Healthcare. I'd like to ask the panel, with a considerable amount of medical devices, particularly dressings, tapes and bandages, coming from the Far East, how might the recent impact of the coronavirus and the movement of goods impact patient care? And I'm thinking specifically really with the community in mind, where there probably isn't a very large stock in the CCGs.
Okay, do I go to Miranda to start that one off? Is it yourself or Joe that would answer that? Do you want to take it, Miranda, or not? Go on, I'll give you a chance. Go on, have a go.
Yeah, well, I guess in terms of the stock that we look after for supply chain, it's more acute trusts as opposed to CCGs. However, from a community perspective, there are a number of community trusts that do buy through our route as well, so it would touch some of them, but not all of them. What I do know is that the guys who are responsible for the logistics and supply chain under the NHS supply chain contract Unipart have been working really hard with the Department of Health to put contingency plans in place in relation to analysing which stock is potentially affected that's coming out of the Far East, whether we need to stock build on that basis, working really closely with suppliers to understand where there's potential alternatives. And then also there's the PIP stock as well, which would potentially be used if we needed to as well.
Okay. Anybody else want to comment on that, or should we move on?
Outside my
Any more questions? Is there anybody else in the audience who'd like to? Oh, sorry, Richard.
I'll just make one comment there from a supplier perspective from industry. There is a focus at the moment on dropping the cost of dressings and the unit price of dressings. That does tend to force the production of the dressings over to China, which does exacerbate problems when things like this happen with coronavirus. You do end up with those problems. And my challenge back to the panel is, by forcing manufacture over to China, how we're helping with the ongoing sustainability of the NHS. As in environmental.
Yes, understand where you're coming from.
Yeah.
I'm going to now take another question from Facebook streaming and stay on product for a little while now, okay? So John has sent in a question which states, product quality and efficacy is paramount to healthcare staff on the front line and to patients. Are we honestly going to see this, or is it just the cheapest product choices for NHS supply chain? That feels a bit loaded too, but let's have a challenge on it, shall we? Go on, Joe, go for it.
Okay, so what I would say, I mean, since the new operating model was launched in 2018, the function of my function basically was a new part to the supply chain. And the intention was to ensure that products are not only value for money, which we all expect as taxpayers, but that they are fit for purpose, safe, and they represent user needs. Now, since the launch of the CAPA team within NHS supply chain, we have launched an assurance framework which looks at quality, and I'm sure Miranda can add to what I'm saying, as far as the idea is that that is applied to absolutely every product that comes through the supply chain, and my team assure the work of the towers to make sure that it meets that criteria. Quality is the first point, and that's really why we're working with the National Wound Care Strategy, and obviously the recommendations that come out from them with regard to wound care would be directly implemented within future procurements. So quality comes first, but obviously we do all want value for money for the NHS as well.
So what I'm hearing is that you're saying that whatever comes out of the strategy in terms of approach to products, you see supply chain with a responsibility to implement it.
Absolutely, yeah.
Can I add to that?
You may.
We do not have a remit around procurement of particular products. So we will make recommendations we will provide clinical advice about what we are seeking. But we are working at a very high level, so we are not working at a particular product level. We are talking about things, for example, a consultation that went out recently. We would really like to see things like the wound pad size of a dressing on the packaging. That's the sort of level we're talking about. We would like a system for absorbency that actually indicates, in a way that we can understand very easily and quickly, whether something is very absorbent, a little bit absorbent, or somewhere in the middle. That's the level we're talking at. And then we are not experts in procurement. We do not pretend to be, and we pass these expressions of clinical wish onto supply chain and similar bodies to say, this is what you've asked us what we'd like, this is what we'd like. But that decision making is not National Wound Care Strategy responsibility.
I think there's a couple of points I'd like to raise. So Joe, your point about ensuring quality and that products are fit for purpose, I would argue from an industry perspective that that's the job of the Medical Device Directive, Medical Device Regulations, and the CE marking. So all of the products that are sold in the UK have already undergone that level of rigour to show that they are of a quality standard. One of the things that concerns us as industry is what we tend to focus on is the price of a dressing. But the dressing itself only accounts for, to Julian's work, 10 to 13% of the total cost of wound care. And what we'd rather do is work with you in combination to say, how can we look at the whole pathway and generate value and better outcomes across the whole pathway, rather than a singular fixation on the unit cost of addressing, which may actually have a negative impact and may actually end up costing the total pathway more. So that's...
Can I come back?
Yeah, you can, and then we'll go to Alison.
I think we all agree on that. What we're all focused on is improved outcomes for patients. But obviously going back to Lord Carter's principles around unwarranted variation, if there's warranted variation, you can demonstrate improved outcomes, that is justifiable, and I don't think anybody would argue about that. But where we do have unwarranted variation, then obviously looking at the sustainability of the NHS, then obviously we need to be looking at that to get the most for the NHS to make it sustainable. So I think there is I totally take on board what you've said, but there is a balance between that, because there is an awful lot of unwarranted variation which was established in Lord Carter's report.
Yeah, and I think it's I think someone on the panel, it might have been yourself actually, Joe, said earlier, it's about setting, or maybe yourself, Una, about setting the specification of what is required and then taking that specification to NHS supply chain to procure against it. Perfect. It makes perfect sense. But I think what we're seeing is that NHS supply chain are almost going and making the decisions before that specification is been set.
So what you're saying, Richard, is you're not seeing that played out in reality. Can I go to Alison?
I mean, is it not better to invest, when we're talking about patient quality care, it isn't, about, the unit cost of addressing. Isn't it better to put more emphasis into how particular products are used to the best of their ability, instead of just, mopping up a leg and visiting twice a day every day, which happens in district nursing today still.
Absolutely.
In primary care, investment into like we already said about GPs, practice nurses, into nursing homes, where there's a massive gaping hole of patients who have an inequality of their wound care management.
I think that's... Una?
I just want to support that. I think the improvements we're going to make have got very little to do with the dressings. As far as I'm aware, most dressings, all the dressings I've come across in the UK are of adequate quality. I'm sure there are some exceptions to the rule, but generally speaking, the quality is okay. The question is people choosing the right type of product to address a situation. One of the classic unwarranted variations I see is the underuse of compression therapy, which I think is what you're talking about, and probably the overuse of very absorbent dressings. It should be the other way around, because most of those wounds, from what you've said, Christine, are going to be lower leg.
Yep.
Most of them will be probably due to venous disease, for which case compression therapy doubles the chances of healing. So we should be looking at increasing compression and maybe worrying less about how much absorbency there is in a particular problem, because that's fiddling while Rome burns.
Okay, and I actually think that's the whole point of the sequin.
Yes.
Am I right in that?
Yes.
Okay, so that sequin is really, really important in terms of its implementation. And of course, the biggest problem we've got, again, Una, there, is that the implementation of the sequin will rest with commissioners of actually putting it into the programme as they move forward.
It's questionable how much choice they'll have. I've been trying to get an answer from the sequin team about this. My understanding is that if you commission a community nursing service, you have to have a minimum number of sequins. There aren't many community sequins, so I think the leg ulcer one is probably there's probably not going to be many who won't. That's my understanding from the sequin team.
Okay, that's cool.
But
I'm trying desperately to stay a bit away from compression because...
Sorry, it's an easy example.
No, it's good. It's good coming from you rather than from me, because I'm kind of wedded into compression in the world I live in.
I just wanted to make another point around the unwarranted variation, and it really picks up what Alison was saying. Unwarranted variation isn't just about products, it's actually about the way the clinical outcomes.
Yeah.
So it's when we're talking about unwarranted variation, we're not looking at any one thing in isolation, we're looking at the totality of it. So I just really wanted to flag that up.
Can I just ask something for my own clarity, because I'm not quite sure about this. Are we actually talking about limiting the number of products that are accessible for use by a specialist nurse or a district nurse, or are we still leaving the door open? I don't get where we're at with that. Can somebody help me with that?
Well, the National Wound Care Strategy Programme has no intention of having a national formulary or limiting products. That is not within our remit. So I can put my cards on the table there.
Did anybody did somebody want to pick that up?
That's not how it's feeling out in practice, and I'm not blaming you now.
I've said it repeatedly, yeah.
It's the national contract pricing that's happening around the tariffs and supply chain. It is limiting our choices massively. We do feel like we're having a national formulary pushed on us. For some of the category groups, we're getting choices of 3 dressings. And for our patients, they're all very individual, very different. I work in acute care. We have massive variation of everything from trauma to oncology to neonates to elderly care. One dressing doesn't fit all. We need to have choice.
Do you want me to?
And I appreciate the variation control, but there is that added problem that actually we might be being limited too much.
So before you answer that, Jo, can I just ask something directly to yourself? Can you just say who you are and where you're from?
Yeah. I'm Carol Young. I'm lead tissue viability nurse at Adam Brooks Hospital in Cambridge.
Okay, so just from your own perspective, and I'm not asking you to kind of 100% nail your colours to the mast, but do you feel that it is actually limiting what you do as a potential to limit what you do and take away your...
I feel there are times I have to make compromises now, that there are patients, I'm having to think, what can I do with what I've got in front of me? Some of my patients need dressings that haven't been...
That you can't get.
That I can't get anymore. We've had to make massive changes, and I'll just give an example of the post-op island dressings that have just recently undergone the national contract pricing. We'd already done a localised evaluation, costs and everything else, implemented a massive change in our trust, and we've been forced to change to an alternative product. Now, I can understand with the pricing, but added to that is the time and effort it takes us as TVNs, our procurement guys, to change all the codes and the shelving and the stock.
Cost high.
There's a hidden cost that I'm not sure is being taken into account. The time and effort it takes in a big teaching university hospital to persuade many, many surgeons that we're having to change their post-op dressing yet again. And really it is because of cost more than anything, I feel.
Okay, do you want to pick that up, Jo?
Pick that one up.
Oh, right, okay. Whoa. Okay, go on, Miranda.
We fully appreciate that there is challenges out there in terms of cost and time of making these changes. I think for us on that basis, we do a lot of work with our clinical engagement team that's embedded within the towers to understand what specific areas that an NCP would work on, nationally contracted products would work on. I think in addition to that, we've had a lot of insight from the CET reports that were done a couple of years ago to again compare and contrast a lot of the products that are on our framework to understand whether it's fact or myths around different products and different brands having a kind of higher perceived quality. And we fully accept and appreciate that in certain areas there is a hierarchy in terms of product quality, but in certain areas there is a generic nature to the products as well. So those areas where there has been a generic nature to those products, they're the only areas that we've wanted to go out and look at where we could potentially standardise and rationalise. So in particular in wound care, there's only 5 areas so far that we've done an NCP on. Based on the feedback that we've had, accepting that there are, like you said, some challenges out there, we have had really positive feedback. It's not just about the savings, it's around the fact that we have, in a sense, forced clinicians to have to look at other products where there is potentially loyalty to certain products at the minute, and the feedback that we've had back is that the products are working in trust and they've successfully been able to carry on their duties with these new products. So for us, it's been successful. Where there are challenges, there is an opportunity to put those challenges through to CAPA through an exceptions process if there is a genuine belief that a different product is required for your procedure. But again, we've only had a couple of exceptions so far on the wound care areas.
So I'll come back, 2 things, 2 observations. So do you perceive yourselves as actually taking away clinical judgment here? Because, I understand where you're coming from, but actually are we diminishing? I mean, we've just started talking about the importance of the role of the TVN, but if you take away choice, are you taking away with that the ability of the TVN to make a clinical judgment? Can I, do you want to pick that up, Joe?
So I would actually argue that we're simplifying things, because actually the two exceptions that came, I've had two exceptions that have come through. And the first one, it was that the adhesiveness of the product wasn't appropriate. Now, from the CET reports, we actually looked at the measures and the comparisons between the products that were in question, and they were exactly the same. So there was no justification for why you should have a different performance with that. The second one was around the sizing, and actually from the information that we had available for all of the standard sizes, there was it was at 1 and 1.5 centimetres. So actually looking to the future sustainability of the NHS, the fact that we can do that and provide options that they're actually giving you comparisons between products, that to me is really, really important. And going back to what Una was saying earlier around absorbency, when you look at a lot of the products at the minute, and like I say, I've worked in wound care for a very long time, when we look at products and we say that they're for heavily exuding wounds or whatever, as a clinician, it's not very clear to you at the minute about what that measure is, apart from what the marketing is on the box. What we're trying to do is guide you by having that information as part of the specifications. Now, up until now, there's been a transition, because obviously the procurement cycle goes for about 4 years, and a lot of the NCPs that have come up recently have been in transition because they were in flight when the work of the National Wound Care Strategy became mobilised. And so some of that's historical, but what I can see from the results that we've had with that, actually it's supporting clinicians. I recognise some of the challenges, but I think that's some of the work that we need to come together to work through.
Okay, I am going to come back to this. Alison, and then Una, please, and then Richard.
Yeah, I just wound care to me, to Carol, to the other TVNs who are here, isn't simple to us, because we deal with a very chronic, very complex side of the patient care. And a lot of the products that we use are advanced products, and they have very specific roles, and a fear for us. Carol, you work in acute, I work out in community, and we still are using a formulary system. A lot of people are using different buying systems, and obviously in the acute trust, many of them supply chain is their supplier, and so we are fearful that for our patients, that we're not going to be able to, we just don't want to pick of 1, 2, 3 off a shelf. That there is much more to it from that patient care perspective, I feel.
Are we well, the only question I'd add to that is, are we limiting what GPs are going to be able to prescribe? Yeah. Una?
Which brings me neatly to my part. I normally duck out of a conversation where I can on wound care products, but because ultimately there's a lot of what I'm picking up is actually nothing to do with the strategy programme. It's to do with just difficulty with supply chain ways of doing things, and which isn't my problem. Well, it is my problem, but it's not my problem. Anyway, what I was going to say was we have a supply and distribution work stream in the National Wound Care Strategy Programme. And what that will be looking at is, as you probably picked up, and I think what you alluded to, there are actually lots of different ways of getting hold of the products you need to deliver wound care. So we happen to have 2 people from supply chain here on the platform, but there are lots of other ways as well. There's prescription, there's the direct supply methods, there's all sorts of different ways. And what we are trying to do in the National Wound Care Strategy Programme is look at the pros and cons of the different systems, because different situations will require different supply solutions. We are not going to be recommending this is the best, but what we will be saying is all these different systems of supply have advantages and disadvantages depending on where you work. And what we would like to do is be able to give those in charge of making decisions about how wound care products come into their organisation things to think about when they are making that decision as to which is the best route for that particular organisation.
Hearing that, I take that on board, Una, I take that on board, but clearly that's very difficult for acute trusts.
Yeah,
and
I think acute trusts have a particular problem.
Very, very difficult when your budget has been top sliced and actually your organisation is saying to you, I don't care what you're saying, this is how it is, you've got to live with it and get on with it. Slightly different in the community because there's more flexibility still there and will remain so, I hope, for some time to come. Julian, I saw you jotting a few. Do you want to make any comments at this point?
My point is just take the argument off a tangent. All I was going to say is that if the clinician isn't able to select the right product for the right patient at the right time, that has the potential to increase time to healing, or even lead it to a wound not to heal. The consequence of that is that, one, you increase the potential for complications such as wound infection, you increase the resources required to manage the wound, and you'll ultimately increase costs, so the burden of wound increases. So it becomes a negative cycle.
And a whole circular thing starts again.
So that was one point. The other point is, there's been much talk about unwarranted variation in products, but many of our studies also reported not just unwarranted variation in products, but unwarranted variation in the way patients are actually managed. And that's a separate issue,
yes,
which also needs addressing.
I would agree. Richard, and then I'm going to move on.
I think, Julian, you segued into what I was going to say very nicely there. I think the point made about, one dressing being the same as another, genericizing them, is fine as long as the wounds are exactly the same. But what I'd be interested in is, what's the evidence? So we've restricted your choice, Carol, and we've saved on some dressings, so we've ticked a box. The 10% costs have gone down by 10%. But where's the evidence to what Julian was saying? Have you had more nursing time? So the adhesion wasn't as good. Did it drop off? Did you get more nursing time? Are the outcomes better or worse? We'd need to see the whole evidence to see whether actually we'd had a benefit on the total cost of care, or have we just saved on the procurement cost of a dressing.
Can I just make a point? If you actually look at when we say about adhesiveness, if you've measured both dressings and it's the same, why would you expect to get differences in outcomes?
But was that a measurement in a laboratory, or was that?
Yeah, it was.
But different patients are different, aren't they?
Absolutely.
Different levels of exudate.
Absolutely, I totally agree. But if you're using a starting point of how you're measuring them and they both perform exactly the same, then you've got to use the basis for that performance. If you're using a dressing on a patient that's got fragile skin, or they've had chemotherapy, or they have, other complexity, then obviously that determines an alternative way of approaching it. But ultimately, if you've got some basic measures that are equivalent, then there is no reason to think that the performance of that would be different, and that's why it's really important that that's part of the specifications.
But I think exactly as you've said, I fully agree with you, Jo, with all of those things, all those different morbidities, comorbidities, etc. What it's saying is the clinicians need choice.
Yeah.
So
I think that's the important
a standard
point.
wound, fair enough, put a standard dressing on, but they've got to be allowed the choice if some of the things you highlighted there are true.
Yeah, but that's again why we aren't having things like
Sorry, Miranda.
So we're ensuring that there is still choice available. Yes, there's a reduced
can you say
choice.
That again?
That's why, for example, we don't award on a sole basis. So there's never a situation where there's only one supplier supplying a particular product. Okay. There's always a choice. It might be a reduced choice, but again, like Jo said, if quality is built into the specification, which it absolutely is, the choice that's left at the end of that procurement process is still fit for purpose.
Yeah. I realise that I'm banging on about this a lot, but I honestly do feel that if we put this situation in front of a group of GPs, we'd have absolute bedlam on our hands in terms of the right to prescribe being taken away from them. However, let me go to another question over there, please. Could you say who you are, please?
I'm Rosa Callahan. I'm Tissue Viability Lead for Worcester Health and Care Trust, and I'm afraid your worst nightmare has been actually realised within our trust. Our formulary for the community has actually taken in the recommendations from the towers, and that is exactly what they've put on. We had no choice. Our trust is really complex. It's like a lot of other trusts. It hasn't just got the mainstream of patients. We also take mental health, which have got their own needs. We've got children's, which again, you need the smaller dressings, etc. for. So we're now stuck with just one choice for those dressings. And one choice, that's all. And a lot of our patients now are losing out. Some of them have even gone to purchasing their own dressings.
Okay. I'm sure that's not the intention. Am I right? I'm
There
sure that is not the intention.
No, there hasn't been a scenario so far with the 5 procurement exercises that have been conducted where there is only one choice in product. I think the smallest we've gone down to in terms of rationalising is down to 2 suppliers in one area. Others have had between 3 and 5 suppliers to choose from.
What they've done is they've interpreted, because there's a first and a second choice, they've interpreted the first choice as the choice to go on our formulary.
Right,
And
so it's
that's-
been
So
masked
it's the
further
product of
afterwards.
choice you're saying.
That's what they've done.
And that's the danger,
practice.
isn't it?
That's the way that
So,
they've
so hang on a minute,
interpreted
you're
the-
saying that's a danger,
It
Alison.
is, because-
So it's about interpretation, are we saying
Yeah,
now?
because every trust has to cut costs. We know that. The NHS is in financial crisis, so they'll take it literally beyond the point and cut it down, as in Rosie's trust. So we literally won't have the choices of, say, I mean, to me, having 3 products per category isn't a choice, not when it comes to patient care. I think we look at it as clinicians from a very, very different perspective as you would in procurement.
Would
Can
we,
I just
sorry.
say, I'm a clinician, so I would say that, you know, from my perspective, I look at everything as though it was my family. So I think it's unfair to say that. But what I would say is, I think the other point is that we're looking to try and find a solution for the whole of the NHS. And yes, we all accept that products are part of that. But there is also recognition around when we're looking at some of the variation, not only in clinical practice, but also in products. We need to really look at that, and we need to approach it as a system.
Okay, Una.
Just a couple of points. Firstly, it does sound as though actually the decision is what's been happened at your local level rather than nationally. So that is an issue that we need to be, you know, so sorry, but you need to be challenging at local level, because it sounds as though there is access. And I forgot my second point. How annoying, while I'm being televised or whatever.
Maybe it'll come
I'll
back
have to
in a
save
minute.
it,
Maybe
yeah, I
something
can't
else
think-
will make it come
Yes,
back.
sorry.
Richard.
I just want to maybe just reiterate the point again. First of all, we agree, as industry, we absolutely agree that we need to drive better clinical outcomes, better patient experience, and drive down the overall cost of the NHS. We're 100% on board of that.
Well, I think everybody would be on board with that, Richard.
We're 100% on board on that, but it strikes me that, yes, we're wanting to look at unwarranted variation, but maybe the easiest place to go is the dressing, because that's tangible, and I can see a saving there.
Exactly.
And what I'm urging the panel to look at is the unwarranted variation of care, because you'll have a much bigger impact. And I think Julian,
that's exactly my second
point. Okay, Una, pick that up.
By focusing on the blooming dressings, we are not spending time looking at this stuff. Look what we've just done for the last 20 minutes.
Exactly.
Floating point. We've gone for the easy thing, and actually it's the least important thing. Yes, it matters, but it's so unimportant compared to everything else, and we fall into that trap in this discussion. So I think guilty. You know, we've allowed ourselves to spend far too much time thinking about dressings, not enough time to talk about the other stuff.
So I think it feels to me like there's been a little bit of an abuse about the context or the use of the language unwarranted variation, because certainly from my perspective, unwarranted variation did always relate to care, not necessarily to the use of products.
Yes.
But clearly, I have to say, for some of the members in our audience, the use of products is about people's livelihoods as well. So we can't kind of lose that little bit of the jigsaw too. And to kind of bring this piece around industry to some sort of conclusion, if for instance the industry is limited, let's say the industry becomes limited around what products they're able to sell. Let's say that actually comes to fruition. Okay, and that's the end point we're aiming towards, although we're not making that explicit. Let's say that's what happens. What happens then to the amount of education, the amount of innovation that the industry brings to the table? What will happen to that? Because that would concern me anyway, because I certainly know that the industry provides huge amounts of education. I think today wouldn't be happening without them to a degree. But Una, if you'd like to pick that one up.
2 points. Firstly, we're very grateful to industry for providing education, but I don't think it should be the responsibility of industry to educate the NHS. That doesn't seem reasonable. I don't think you rely on us to educate your staff. You have educational programs that rely alone. So while it's very nice to have, I don't know that it's a right ask for the NHS to depend so heavily on industry for their education. Innovation, I welcome innovation, but I want innovation that's effective, not just something that's new and shiny for the sake of being new and shiny. So of course we welcome innovation, but we need innovation that delivers meaningful outcomes, That's the only innovation we can afford to be interested in. We're always going to be broke in the NHS. It is
Absolutely.
the nature.
Absolutely.
It is not going to change because you have a situation where the demand for healthcare exceeds the amount of money the taxpayer is prepared to pay towards health. So we're always going to have that tension. So we kid ourselves if we say it's going to get better. It isn't.
I'm going to take 2 more comments on that, then I'm moving on. I agree with what you're saying, by the way, Una.
Thanks.
Me.
Absolutely, Alison.
Okay.
You.
So I just wanted to just mention about the education point, because so in the NHS today we are having problems with staff being released from, whether it be in the wards, whether it be in community teams, to access education. Those classroom-based education sessions are, you know, by the by these days. Events like this, a lot of staff that we've got this week, conferences, staff are taking their own days off, their own annual leave to be able to attend. And, you know, education shouldn't be, you know, some special event. It should be mandatory. That's, you know, in that, you know, the staff that are coming to the conference are all working in wound care and they want to update their skills. But without industry, these events can't happen. We can't get beyond that it's the fact that you're paying for the exhibition. The things that, I mean, I do a lot of the Facebook Lives and things like that where we're delivering that education and people are happy to sit at home on the sofa with a cup of tea at 7 o'clock and watch me talking about whatever that may be. And, you know, we have to look at different ways forward. But we can't forget that industry do provide that. And in my NHS, in my own NHS working, as that sole TVN in community, I can't deliver my education all on my own. So I do rely on that partnership with industry. In our nursing homes, for example, I really rely on industry to deliver my formulary information out there to them. So to me, it's really, really important, that partnership.
Can I just go to Richard first,
Certainly.
Julian? I'm sorry.
Maybe industry could talk, and give its view. Thank you. I think you're absolutely right. I think industry, the UK is often seen as a gold standard of wound care worldwide, not just in Europe, worldwide. I don't want to over-dramatise this, but I think it's at danger of losing that gold standard status. It's fair to say that we invest a lot. We invest in innovation. And innovation doesn't have to be just, you know, world-changing or something shiny. Innovation takes us from a dry dressing, or God forbid, egg white and oxygen, to where we are now.
Innovation that works.
Innovation, absolutely. Innovation that works.
Yes.
Because the UK is seen as the gold standard, a lot of the innovation is born here and designed here. But if we no longer have the money here, that innovation will be taken offshore and other countries will get first choice. The reason we would stop investment, if there's a race to the bottom on price, our margins get eroded. The way we pay for investment, the way we pay for innovation, the way we pay for education, and education goes a lot further. It goes to the journal advertising, it goes to the journals, etc. Our ability to invest in that will drop, and as a consequence, the impact of industry will become a lot less within the UK.
Can I just pick up what you're saying about goals? Are you saying that innovation is gold standard, or are you saying that care is gold standard?
I think,
what are you saying?
I think everything. I think basically the care, believe it or not, wound care in the UK is seen to set the standard across Europe, without a doubt. The NHS system allows that to happen. As a consequence, a lot of the innovations that happen in wound care, not just product, but service innovations, are born in the UK.
Would you want to comment on that, Julian, about being gold standard in the UK right now? Not going forward right now? or am I asking a difficult question again?
Would you like me to?
I'd like Una to answer.
Go on,
that,
go on.
I think you're right. We have a unique, I think, social experiment with the NHS. And, you know, gosh, we all remember the Olympic Games. It's one of the things we're most proud of and we're most critical of. It is unique, and I think that makes us an extremely valuable place to test out innovation. I don't know whether we've got gold standard care because, frankly, we haven't got a way of measuring it at the moment. So I don't know, and I think other countries are probably in a worse place than us. We do some good stuff, but we do some stuff which could be a lot better. So I can't really judge on that. What I do think we do have, it's a wonderful testing ground for innovation. Yeah. Now, whether that's due to industry, and frankly, whatever happens to the price, that will continue because we have it's very imperfectly joined up, but it's actually a lot better than some other areas. And interesting, the last election, whatever you thought, it was the fact they said, oh, we will invest in the NHS. All parties said that because it's recognised as being something so valuable that we have got to try and protect. So I can't really answer your question.
The only point I'll pick up is you said, frankly, innovation will continue. Not necessarily industry born, though. Not necessarily. If we find it more attractive to invest elsewhere.
Okay. Okay. I want to move on. Because we haven't touched yet on primary care and practice nurses. So I think this is. We talk about the challenge of dressings. I think the challenge of general practice and getting practice nurses on board and engaged with wound care is a massive challenge out there. And do primary care networks provide an opportunity for that? Would somebody like to kind of pick that one up? You're doing well today, I have to say.
It's the top of my brain, actually, because I was talking to a journalist at the end of last week who's publishing an article on this topic.
Right.
I think what's the real opportunity with primary care networks is that they start to move towards that more integrated way of working. Though I do think integrated care systems are even better because, as we alluded to at the beginning, we have got to get better at working across the boundaries in order to make wound care better. So coming back to primary care, I would be delighted if everybody in primary care, when they were presented with a wound on their lower leg, recognised this wasn't likely to get better by simply sticking a dressing on it and giving them antibiotics. I am not expecting every primary care GP or nurse to become a tissue viability nurse. It's unrealistic. But I do think what is reasonable is for them to either be able to organise themselves to work collaboratively with their tissue viability team to deliver a suitable service, or to be able to refer to a suitable service. And there will be, I'm aware there in some parts of the country, there are some primary care teams that are already doing that. And they're to be congratulated. I don't want to take that away from them. If it's working, great. I've told this story before. I have probably one of my oldest friends is a GP. And I tend to test things on her because she's an average GP, and I mean that as a compliment. You know, she's a good, solid GP, but she's not. She gives it to me how it is. And I said, what do you do when people come to you? She says, oh, it's great. She said, I look at them, she said, and I think, oh, there's a wound on the leg. Right, need to refer you to my leg ulcer service, which they have commissioned locally. And she said, sometimes, in fact, sometimes I'm a bit naughty. They come in to see me about a chest infection. She said, but I happen to look at their legs and think, oh, I don't like the look of them either. I refer those too. And wouldn't it be wonderful? And she can do that because she works somewhere where that service is possible. So not only are they doing the right thing to heal, she's also doing preventative, because bless her, she's known me since we were 11, and I think I've probably burnt her ear on a few things. So that's what we need. That's what we need.
Okay, Alison, I notice you want to have a view there.
Primary care is something that we know need to be tackled. You know, if we go back to the Betty story that we know, right care first time, until that's tackled in primary care, a lot of that, lower limb burden, won't disappear. I did an audit in my trust when I went to work there 3 years ago, and we do have a leg ulcer clinic specialist service, but still patients were sitting in primary care for weeks, months, years, having dressings applied, having antibiotic courses. And then there's a clinic there, it's been there for 18 years. It's not that it's not known about. So there's a lot of education. And do primary care want to take it on?
Well, I was about to say, it's not actually in a GP contract, is it?
No, it'll need to be local enhanced service type stuff.
They need a carrot dangling to take that on, don't they? As they do with other chronic wound, chronic comorbidities.
Yeah. And any other comments on that around primary care? Because for me, primary care is a real kind of opportunity.
I don't think it's their responsibility to solve it, but I think we need them in the conversation to find a solution.
To actually engage them in the process. Yes. Okay, so that takes me on as we're kind of moving and meandering towards things around the NHS plan with primary care networks. What about prevention and self-care? Where does that sit in all of this? Because we haven't really touched on that yet. And there must be something in that whole perspective. Alison, see, you've taken the lead from Una now in terms of wanting to get to those. We've got a race in the middle here. Yeah. Okay, so go on.
Yeah, I think that, again, that is a really big point. We're talking about, nursing time going going out, we talked about the dressings and the costs and everything, but what about giving some of that autonomy back? I was recently looking at, because I'm sad, and I was just looking at a document from the government about the ageing population, and the statistics of that is, you know, we know over the, you know, the next sort of 50 years, the percentage of over 65 is going to be much higher than the younger generation. So we've got an ever increasing problem, and with that will become, you know, there'll become more wounds and more leg ulcers with that. So do we need to start now, and where's the starting point of handing that back over to patients? You know, there are some solutions in patient care, and I think historically within the NHS it's always been, you know, the patient comes in, nurse, there's my leg, you know, get on with it. So we need to change that perception and invested in that, in, you know, whether that's public awareness, health promotion and education back to the patient. It won't, we can't fix it all, obviously, you know, not everybody's going to be able to do that, but we've kind of got to start it before it gets out of control.
So Una.
I would fully agree with what you're doing, what you're saying. I think that's already started. I mean, again, we've talked a lot about the lower limb, and I mentioned this morning, there's the Legs Matter campaign, but I think the other thing that is already there that we're not encouraging use enough of is NHS choices. Let's work with the systems that already exist. I said this morning, I do not know why the government isn't promoting, or that we don't have adverts about NHS choices. Have a look at the information that's on NHS choices. It's not perfect, but it's not bad. So rather than inventing a parallel system, let's work with the system we've got and raise awareness of it and make sure the information on there is right, and also signpost people to places where they can get more information.
Okay, Joe.
I was just going to add that there was a really successful campaign quite a few years ago now about, you know, when you're on a plane, anti-M stockings, which was a huge success, about prevention and lower compression to avoid, you know, embolus when you're on a plane. But we've never had the same success when we're talking about chronic venous insufficiency and the prevention of leg ulcers. And I don't know how you get that balance about educating people and them actually actively doing something about it before you've actually got the end product of a leg ulcer, and I think that's maybe something.
I think you're making a really important point there, and I'd put alongside of that the issue of swelling that comes alongside the issue with leg problems. And you know, it's interesting, isn't it? Prevention could be the easiest thing in the world to do if actually every clinician at the primary care end actually check legs. I find in my, you know, when I'm out and about, I'm looking at people's legs. I'm kind of going, oh my God, you've got problems looming, lovey. And, you know, because you do, if you're in this business, you tend to look at, it sounds a bit wrong really, but you do tend to look at people's legs and think there is a problem, and how could that be prevented before it actually gets to the point where actually it's something not very nice. Alison, you were going to say something about that there, were you?
I think
were you actually going to
I was just smiling because I found myself at Christmas, I can't remember what I was buying, nothing to do with this topic, but found myself at the counter in Boots, and there was a young girl there worrying about her legs. So I ended up in the, you know, the little room they have with the pharmacist doing a spontaneous consultation, because the pharmacist didn't have the knowledge they needed. And actually, yeah, she probably did need to see a GP, but she was about to rush herself off to A&E. It wasn't an emergency. I gave her the information she needed, that if it did suddenly deteriorate, obviously she needed to get there, but make an appointment with your GP, see if you can get a GP who knows something about dermatology, and on you go. Okay.
I think you've hit another point there, talking about pharmacy as well. You know, is there any? You've been very quiet, audience. You're very quiet. Is there not one more question before I start to kind of summarise where we're at today? Is there not anybody who's got, you know, a real burning question out there that feels that we've absolutely missed the point totally in what we've done here this afternoon? Here we've got one. He thinks we've missed the point totally. There you go.
He stuck his hand up just as you said that, didn't he?
I may regret this now. Sorry, Mark Rigby from Ergo Medical. Are there any learnings that we can take from parallel nursing industry? So the role of an infection prevention nurse is the clue's in its title. So they're there to prevent infection. If there's an intervention that changes and we see a rise in hospital-acquired infections, then that would be a negative outcome potentially. What would be the outcomes that the panel would look for in wound care?
Ooh.
Things getting worse or better? Or both.
Anybody want to handle that one? Outcomes in wound care. What we're looking for?
Well, the first thing I think, it depends, doesn't it, on the area. If we look at pressure ulcers, obviously, ideally we want to prevent, and that's quite difficult to actually measure. prevention. There are ways of doing it, and they're doing it to a fairly successful degree. Interestingly, with pressure ulcers, the one that's emerged, because I always assumed if you've got somebody with pressure damage, if you remove the pressure, they would heal. And what we're finding is that actually that doesn't necessarily follow. So there's now also some work to be done around healing, particularly of complex, deep pressure damage. So that's one thing. I think with lower limb, it has to be around healing rates and prevention of recurrence. Surely those have to be the outcomes we look at. There are some interim ones we could do, but actually that's the nub of it. Surgical site infection, open surgical wounds, which is the other focus point for the national strategy. Obviously, prevention of surgical site infection is of interest to us, but actually some wounds, I'm told, seem to break down without actually any obvious signs of infection, and that data isn't being captured at the moment. And interestingly, although GIRFT and Public Health England have got 2 separate audits going on, actually diagnosing surgical site infection is not straightforward, and I think there's big question marks over the quality of the data, and it's usually being done by pretty junior clinicians, junior medics. So I don't know how good that data is, and it's not being collected outside hospital. So again, it comes back to this need to work between community and hospital, because classically, so many patients now are being discharged early that if their wound breaks down, it breaks down once they get home, not necessarily in hospital. And we're not capturing that. So I think that's another outcome that needs looking at. So that's a few to go at.
Okay, that's good. That's good. So unless there are any further questions, we've got one over there.
I'm Sandy from Cambridge Healthcare Supplies. Una, earlier you briefly commented on primary care and GPs, mainly actually saying, right, here's antibiotics, put a dressing on it as such. The new NICE guidelines came out last week for infected leg ulcers, and I'd just really like to get...
Oh, I didn't know about that.
Yes.
Who's that published by? NICE
Infected leg
ulcers.
Leg ulcer infection and antimicrobial.
Was that a NICE guideline?
Yep.
Guideline or guidance?
Guideline, I believe.
Well, that's interesting, because I didn't... Because guidance and guideline are 2 different things, just to confuse things.
I will double check that one.
Send me the reference, I'd like to know.
But yes, they've published a guide something. About antimicrobial prescribing.
Yes.
And absolutely everything on it is oral antimicrobial or antibiotic. No consideration at all for topical antibiotic treatments at all. I know it's
obviously
as old as the hills, but
I can't comment on something I haven't seen.
I'd just like to get a little bit of opinion from yourself and from Alison also.
Right. Difficult for you to do that.
I can't comment because I haven't seen it.
Yes.
That's
what
a tough
I would
one.
be interested in looking at was the evidence they have considered. Generally speaking, the evidence for topical antimicrobials for infection is not robust. That doesn't mean to say they don't work, but there's no evidence it does work either. So I'm curious about that. I would very much like to have a look at it, so please send me the reference. I'm disappointed they haven't spoken with us, but there we go. This happens a lot, or they consult with us 2 days before they publish, which is the other classic thing we have, which makes it very, very tricky. My view on infection for leg ulcers is around the diagnosis. Mm-hmm. I think 9 times out of 10, what they're looking at is probably not infection, but actually the redness that you get with a classic ulcer. Yep. Yes. So I would be very curious to have a conversation with them. Interestingly, I have got a conversation on this topic with the head, NHS England head of ageing and frailty. They're doing some work around antimicrobials. So it'd be very nice. I think that might be that conversation. It's either this Friday or next Friday. So if you can ping that to me and let me...
No, I will.
It would be nice to go in for us, so thank you.
So is there a bit of a lack of connectivity between yourself and NICE?
I refer to myself as the dating agency for wound care, because it's like a many-headed hydra, pops up all over the place. And a lot of the time, all I can do is put things in place. I thought NICE was a body that spoke to each other. I'm discovering
they were
not.
nice.
I thought, well, they've been very nice to us. I did not believe they themselves have reorganised, and there are so many different departments within NICE that don't communicate with each other.
Yeah.
So I don't know about it. I'm certainly speaking to about 3 or 4 different parts of NICE.
Mm-hmm.
That might be produced by another one that hasn't spoken. You'd hope, as an organisation, they spoke to each other. But
having a specific
doesn't
committee
always
there
follow.
with expert testimony there as well.
With the antimicrobial stewardship, you would hope that, like I say, I haven't read that either, that it's not just that's the first line, and what is the infection continuum, that we work from when we're, looking at products that we use or when we use antibiotics. So.
What's worrying is, given how many people are involved with the national strategy, that presumably nobody has been...
It's not fed through to you.
It's not fed through, because I've got pretty wide nets. Not usually somebody says, "Oh, did you know this was under development?" So that's you do wonder, don't you? Thanks.
No, so as I'm going to start to wind up proceedings now, and I'm actually going to throw some questions out to you, and in doing this, I'm probably going to leave myself wide open, but here goes. Do you feel that you have a greater understanding around supply chain and towers and strategy and purpose? Do you feel that's been explained to you adequately? Can you raise your hand if you do? Oh my God. I'm dead. You don't feel that's... Why don't somebody tell me why you don't feel that's been answered? Can somebody be brave enough to actually put their head on the chopping block here and answer that question for me?
My name's Sue Mason. I'm one of a tissue viability nurse, but I'm also a clinical procurement specialist nurse as well. I don't feel there's any kind of approach to it from a tissue viability point of view. I don't think we're involved in it enough. Certainly, with there's been no consultations.
With TVNs?
With TVNs.
Sorry, are you talking about supply chain?
We're talking about supply chain. I'm not talking about strategy.
Yeah, supply chain. So where Rose is concerned, you've got a tissue viability nurse who's got a quite complex group of people, patients, and actually she's had no involvement in that. She's not on her own, because I equally know in another part of the country that they invited the tissue viability nurses in procurement and the decision had been made.
Okay.
And it's an ongoing scenario, so I don't know how it's working. The Clinical Procurement Specialist Network, we have discussions there, and not everybody's happy.
Okay.
I know we're saying that in the room, but they're not all happy. I'm not happy as a TVN. I worked really hard to get where I am, and I'll make a decision on my patient, and I'll prescribe it. I won't be selected down to the last 3 dressings because it's for my patient who'll come first.
Okay, so I think this is a really important point. Now, we're not talking about industry perspective here now. Let's get that clear. We're not talking about cost of dressings or anything. We're not talking about the industry view of the world. We're talking about a TVN's view of the world here and saying they're not involved in this and they feel, I'm saying this phrase, you feel done to, not done with. Now, how do we get over that? How do we get over that hurdle? Because I think that's quite an important point. I don't want people going away thinking, well, I've just sat in there for an hour and a half and I'm none the wiser. So do you want to tackle that, Jo?
I can try. What I would say is that I mentioned earlier on that there's quite a lot of things that were in flight. So some of the recent experience with the NCP specifically, which I think you're probably referring to, is something that's a transition because the process started quite a long time ago. I know that the Tower have done an awful lot of engagement, and I'm sure Miranda will add to that and give you some input onto that. But moving forward, we are following the recommendations, and obviously the ERG that Una mentioned has actually got representation of tissue viability nurses across the country.
We're not to do with the procurement, that I
No.
think is what you're asking
But
about.
the
These are different projects.
Can I just pick that up? I think it's really important now to emphasise the point you're trying to make, Una, here, is that there is clear blue water between yourselves and the actions or the direction of travel or the strategy being taken by supply chain. Am I correct?
We are, as the National Wound Care Strategy Programme, we can express our opinions, views and everything else, but we do not have jurisdiction because NHS supply chain is a body with its own its own rules of engagement and everything else. So we can be consulted as a stakeholder to supply chain.
Yep.
But we do, I think originally there was a misunderstanding that the National Wound Care Strategy Programme was part of supply chain. And I think now most people understand, no, we complement each other. We try to work collaboratively. We try to be supportive because that works well for both of us. But obviously we cannot say how supply chain will operate because they are their own body that we respect. So
so coming back to what you were saying,
what
Jo.
I was trying to say was that obviously a lot of the work that's been done by the ERG informs what we do. And that is really key to it, but there is additional engagement. All I would do is encourage you to get involved with Miranda, I don't know if you want to sort of pick up around the engagement.
First of all, I can take your details and we can discuss afterwards how you get involved in future strategies, because we are at this moment in time finalising the strategy for the wound care renewal, so that's advanced and general wound care frameworks. I think what I would say is part of the tower stand-up for the new procurement operating model, each tower had to have a clinical engagement team. We have our own clinical engagement team. That team are responsible for going out there.
Can I just ask a question? I'm sorry to interrupt you, but are those people, excuse my phraseology, jobbing TVNs?
Yes.
Are they actually
we've got
TVNs?
one here in the audience.
Who's
got one in the room?
One in the audience, okay. Yeah. So are those TVNs liaising with the TVNs out there on a day-to-day basis? Because it seems to me I've got two TVNs in the audience here who feel like they have had no say whatsoever in what's happening.
Yeah, I mean, I can understand that because there are a lot of TVNs nationally. We've got 240 acute trusts with a number of TVNs aligned to each one of those. We obviously can't get around every single trust nationally and engage on every single framework, but we have had significant engagement nationally, and I would say a really good spread as well geographically from north to south, and lots of different backgrounds. In addition to TVNs, there's obviously lots of different industry specialists, different nurses with different backgrounds, and we are engaging with as many of those as possible. So obviously we haven't spoke to you individually,
no,
but we
I
have
think
spoken
from an acute
a
perspective
number.
it is different from a community perspective.
Absolutely correct.
And sustainability in the community is that the patient has the dressing that is absolutely needed for them, and if they have to have it done twice a week, it's better than having it done every day because the dressing is the lowest cost on the market.
I think you're making a hugely important point there, and one of the issues here, well, I shouldn't say this, but I'm going to again. The issue you've got here is the connectivity between the community and the acute trust. They are like this, and it kind of needs to go a bit like that because you need to be aligned to primary care. Then you won't, have those constraints because they don't exist out in the community in its broadest sense. They exist in community trusts. You can't top slice GP practices, you can't do that. Yep. So actually there's a whole other thing going on over here, and we have to recognise that the work in the community is hugely different. I mean, they're poles apart, the work in the community and the work in acute sector. And there may be people who agree with me, there may be people who don't, but we have to take that on board somehow.
Yeah, no, absolutely. I think 15% of our spend is non-centrally funded, so CCGs and community trusts that are aligned with acute trusts in certain instances as well. And if you look at our engagement plan, we are engaging with the community trusts as well. So we try and incorporate views across the board as best we can, really.
Okay, one last comment, Richard, and then I'm going to really wind up now. Because I don't want to lose my audience while I've got a head of steam.
Maybe one point I'd make against this discussion is running a business, you start off with a goal and you make sure that every department within that business is measured by the same goal to the same strategy, and that's the only way you ensure success. One of the fears I have is that the National Wound Care Strategy, with a very admirable goal that we all buy into, its success will be measured differently to that of supply chain. And because you're not acting against the same target and the same exact goal, that's where there's misalignment.
But we're different organisations. We can't be working.
Absolutely.
Absolutely, but you represent the same aim, which is to drive down...
Absolutely not.
We don't. We definitely don't.
Oh, okay, so your aims are different.
Our aims are different. We are not cost-driven. We are about improving care. Our aims are different. And I'm not saying you are either, be about quality. So I think, I don't know about that, but we are...
We got a bit of a... No booing, please.
I don't think that was
I was just about to round up, and I can't now. How can I shut down on that one? Joe, you said you're not cost-driven. Help me.
Where there's quality's first, quality always comes first. But where there is unwarranted variation for no reasons where the outcomes are improving, then that is obviously the quality needs to be driven out for the NHS. So I don't make any apologies for that. I think that's what any taxpayer would want us to do. What it doesn't mean is that our aims as far as patients are concerned are exactly the same. We all want the best outcomes for patients and access to the best services. And actually sometimes that means realigning resources as well. You can't have one without the other, so I don't think pitting them against each other is the right approach. We're all aiming for the same outcome, which is an improvement for patients, and it's getting the balance between the two things.
Okay, Julian, Scott.
As we're talking about the taxpayer, if we were to look at our burden of wound study from 12-13 and exclude the cost of all wound care products, and look at our new analysis for 2017 and exclude all the costs for wound care products, you would still see a massive increase over 5 years, which is a reflection of the increase in the number of wounds, the increase in the resources. So the costs of the wound care products, with all due respect, are somewhat irrelevant. They are. You could cut them to nothing, you will not change the burden of wound care. And if you're talking about the taxpayer, that's what's being spent.
I totally agree, Julian.
I'm going to keep going now. I'm sorry, guys. I'm keeping going. Rachel.
It's a very quick question. Hi, I'm Rachel from Eleanor. How are you measuring quality, Joe?
The quality is around as far as if you're talking about within the category strategy development, we have an assurance framework which you can access online if you want to go and have a look at that. So all of the criteria that we use to ensure that the category strategies are fit for purpose are actually on there, so you can go and have a look online for that. But all of the category strategies need to meet that criteria before we actually approve that to go through for procurement. As I said, some of the historical things that have happened in the past have been transitional before the new function stood up and the assurance framework came into place, really. So you have got some legacy that has happened in the past, but as far as the quality and the criteria that fits with that is all evolved as part of the work that we've been doing recently. But like I say, you can go and look at that online. It's available for everybody to see.
And that will clearly outline how the quality is being measured.
It gives you how we assure against the procurement process is fit for purpose. When you're actually looking, obviously it applies to 11 towers, which vary from food right the way through to MRI scanners. So if you're looking for something that's specific about wound care, the principles of the assurance framework are applied to absolutely everything. So we would expect that to be met for everything.
Okay, so I'm going to have another go now. I don't want to... Go on.
I just want to make one final point.
Go on.
If you want to rethink wound care, I think you need to consider it as a human resource-driven discipline.
Yes.
And I think that's how the thinking needs to change. To think of it that way.
I think this is a fantastic note to end on, because I actually think Julian is kind of bringing everything together and saying, you know what, it's all right having these conversations, but at the end of the day, and it doesn't matter what area you're looking at, if you focus purely on a product, it will not improve what is happening with NHS resources.
Absolutely.
The only way we can do that is to combine how we approach products together with change working practice. That's how you get things to change. And actually focusing purely on the price of a product is absolutely not going to drive where we're trying to go with the plan. I understand it is something that is out there and it's actually a way forward. I think my worry is My big worry is that as we're doing this, we've got a fantastic strategy that's emerging here. And what worries me is that people will end up voting with their feet and say, do you know what, I need to find a way not to do this, which is what you're saying to me over there. The lady over there is saying, I need to find a way not to comply with what you're asking us to do, guys, in towers and in supply chain, which is kind of not where we're meant to be going. And for me to try and get to a place where we avoid that, how can we engage with people more effectively so they feel part and they don't feel disengaged and disenfranchised from what we're trying to do? We have a population out of there that actually is costing a fortune, not in product, but in poor care. And not is it only just poor care, we are actually creating harm because of some of the ways we're actually working out there. The challenge for us, how do we do this together? And actually putting restrictions may not be the answer in wound care. It may well be the answer in other areas. I mean, will we ever restrict the use of insulin? That is an interesting question, isn't it? We may not choose to do that, but we will choose to restrict the use of wound care products. I understand where we're going with the generic side of things, but at the end of the day, we have to be able to bring this all together in the round. And to do that, I'd like to thank you all. I'd like to thank everybody that was streaming in. I feel like I'm talking to an invisible audience, and I'll keep doing this as if it's good. That sounds quite rude, actually. Sorry about that, folks. And finally, can I thank our panel, our guests for today, for the sterling job that you've done.
Well done, Christine.
And last but by no means least, let's hope we get the opportunity, Ed, to do it again next year. Thank you very much.